Today we'll be discussing about glandular odontogenic cyst. This is a developmental odontogenic cyst. It is also called as cyalo-odontogenic cyst, polymorphous odontogenic cyst, and mucoepidermoid odontogenic cyst. Okay, this is an odontogenic cyst with glandular or salivary features of your salivary gland. Okay, that is why it is called as cyalo-odontogenic cyst. Why features of your salivary gland in this odontogenic cyst? It is from the pluripotentiality of the odontogenic epithelium. Okay, and the histopathological features of this GOC, it's got multiple morphologies. Okay, that is why it is called as polymorphous odontogenic cyst, and it is almost similar to low-grade mucoepidermoid carcinoma, the important differential diagnosis. That is why it is also called as mucoepidermoid odontogenic cyst. And it is a rare, as I said before, developmental odontogenic cyst, which is quite aggressive and highly recurrent in nature. And the histogenesis is from the cell rest of Serrae. Okay, and this is, as I already said, it is an odontogenic cyst with glandular features, and it is an intraosseous cyst. You will be able to appreciate the radiographic presentations in this odontogenic cyst. Moving on to the clinical manifestations of glandular odontogenic cyst. It is most common in the anterior mandible in middle-aged adults. Okay, and the lesion usually crosses the midline. The size may range from less than 1 centimeter to very large destructive lesions also. And similarly, your signs and symptoms. It may be asymptomatic or it may present with pain or paresthesia. Please remember, it is most common in the anterior mandible. So glandular odontogenic cyst is a developmental odontogenic cyst which is quite aggressive in the anterior mandibular region with features of salivary. Okay, moving on to the radiographic features. So this usually presents with a unilocular or a multilocular radiolucency in the anterior mandible with well-defined margins and sclerotic borders. Now, the important part of it is the histopathology. Okay, so any cyst, as you all know, is lined by cystic lining epithelium and then your fibrous connective tissue capsule. So that lining epithelium may be of varying thickness with cuboidal to columnar superficial epithelial cells, and the surface you might have varied presentations. Okay, the epithelial, the lining epithelium, the surface of the lining epithelium may present as hobnail cells or with papillary projections or with ciliated cells. We'll be discussing them in detail. So these are the epithelial plaque-like thickenings. Okay, you see similar histopathology in lateral periodontal cyst also. Okay, so these are the epithelial plaque-like thickenings that will project into the cystic lumen. Okay, so this is similar to, this is one of the presentations. This is similar to your lateral periodontal cyst. Then moving on to the mucus cells. You see these mucus cells in the superficial cystic lining epithelium. Okay, as I said, these lining epithelium may be of varied thickness with all these presentations. Okay, so or as I said, these are the hobnail cells. Okay, see, they are eosinophilic cuboidal or columnar cells, okay, with a prominent nucleus, right? So these are the hobnail cells that you will see in the superficial layers of your lining epithelium. And these are the glandular features, okay, duct-like pseudoglandular features. And these are intraepithelial microcysts. They might have mucicarminophilic material, okay, which may be PAS positive. So, see, these are the mucicarminophilic material which is PAS positive. So, these are the various presentations of glandular odontogenic cyst. So, please remember the lining epithelium if you take the varying thickness, okay, with cuboidal to columnar superficial epithelial cells. And you might have hobnail cells, ciliated cells or papillary superficial cells. And you will have intraepithelial microcysts, mucicarminophilic material or your mucus cells. Okay, so based on all these, Kaplan gave a diagnostic criteria, have major and minor criteria. So for your major criteria. And if you see the interface between your cystic lining epithelium and the connective tissue capsule is flat. It lacks three ridges, and your connective tissue capsule, not much of inflammatory cell infiltrate is seen. So coming on to the Kaplan major criteria, as we all know, it is your squamous cystic lining epithelium with flat interface. Okay, and varying thickness of your lining epithelium with epithelial plaque-like thickenings, hobnail cells, which are your cuboidal eosinophilic cells, mucus cells with intraepithelial mucus pooling, and glandular or microcystic duct-like structures. All these will constitute the major criteria. The minor criteria, papillary surface, projections or ciliated cells, or your clear or vacuolated cells in the basal layer. So this is the diagnostic criteria given by Kaplan. So always clinico-pathologic correlation is essential for diagnosis. So what are the clinical manifestations of GOC? Anterior mandible may be asymptomatic or present with pain also, quite aggressive, and it is recurrent in nature. Radiographic, unilocular or multilocular, well-defined radiolucency, and these are your gross features. And histopathology, you see varying epithelial thickness with ornate cells, ciliated or papillary superficial cells, flat interface, okay, and intraepithelial microcysts, glandular features positive for PAS. So the differential diagnosis, it includes LPC, lateral periodontal cyst, if it is going to present with epithelial plaques, and your low-grade mucoepidermoid carcinoma, you have your UC carminophilic material mucus cells and all that. Okay. So what will be your treatment plan? Enucleation, curettage, or your resection? Always follow